Good afternoon, everyone. My name is Allison Fontaine, and this is my applied practice presentation for graduation for Eastern Washington University's Masters in Public Health program. In today's presentation, I'm going to discuss the major works that were accomplished during my applied practice, as well as the activities that were completed, the connections to each CPH competency, as well as a conclusion and reflection on my time during my applied practice. So before I delve too deeply into my introduction, I do want to preface this applied practice presentation with some feedback in regards to my actual practice. I ran into some pretty serious roadblocks with my organization. It took them about 5 weeks to sign my affiliation agreement, which really set me back during my applied practice class. Unfortunately, I wasn't really able to complete things in the timely manner. And so I'm really grateful to Professor Swope, who worked really, really diligently with me trying to get all of the documentation done. Unfortunately, Peace Health was going through some pretty weird changes structurally at the time, and no one quite knew who was responsible for signing what. So it was a little discouraging to go almost an entire term without any movement in this, but I was really grateful for the fact that I was still able to complete tasks in regard to my applied practice during that time, and then use what I had accomplished previously and then kind of retroactively go back and upload some of the documentation. So just really grateful for all of the work and collaboration from everybody who helped kind of make that happen for me. So to begin, the purpose of my applied practice was to kind of increase awareness on the importance of mammograms and develop a free mammogram screening program for those in underserved communities. This has been a long-standing issue where I live in Whatcom and Sedro-Woolley. Sedro-Woolley is part of Skagit County, which is about 15 to 20 minutes south of Bellingham, where we found that a large portion of minority populations and underserved communities were not getting preventative screenings, resulting in late stage resulting and like more fatal diagnosis. Not just with this population that we are working with in my applied practice, but in several other ones as well. So mammograms and mammography screening ratings is one of the CMS clinical quality guidelines that we track in our outpatient setting. It's one of the things that we measure our providers on. And so when we came to recognize the large gap in mammogram screening rates in our American Indian community, specifically within Skagit County, Sedro-Woolley, I figured that that would be a really good place to kind of start with my applied practice, because it was something that we were kind of already having a discussion about at the system level. So my site supervisor was Rachel Lucy. She's the director of community health for Peace Health St. Joseph Hospital in the Northwest Network. She and I have worked together on several projects, so she was really, really gracious in being able to be kind of my supervisor for this. She has a PhD in public health. And so she has just been incredibly supportive throughout this entire program. And my role was to kind of gather the background data on how to make this program successful, as well as compiling the tools necessary to move work forward, gathering the information from our community partners, and assess and plan the necessary meetings and events, as well as kind of facilitating a lot of the work to ensure that it continues to move forward, which given current capacity standards was pretty tough, but we got there. So here is my introduction continued. You can see Sedro-Woolley is kind of outlined by this white arrow. It's the second from the top county in the red. And then you can kind of see on the right-hand side the annual incidence rate by county. And this is gathered from the Department of Health website. So Whatcom, Skagit, Snohomish County, those top 3 red ones are all areas that Peace Health kind of serves. We are the largest hospital north of Everett, so we service a large area of Washington state. So next up, I'm going to talk about the major works that were created during my applied practice. So there were 2 major work products that kind of came out of this time. The first was a free mammography screening program for the underserved communities, specifically the Swinomish and Upper Skagit tribal people. as well as an annual community event that's going to be hosted in tandem with our screening program that discusses the importance of preventative screenings. And the hope kind of moving forward is we have our annual event already scheduled for this month, but moving forward, this is something that we will have on a more regular basis. The hope is that we will be able to have it in October, which is Breast Cancer Screening Awareness Month. But given the fact that our program is going live and has actually gone live, we wanted to have one now just to increase awareness on access and availability and try and engage some more of our community members to just draw attention to what we are offering. So next up, I'm going to talk about activities that were completed during my applied practice. So looking at this a little bit more in depth, a free screening program, not just for breast cancer screening, but other preventable diseases, was proposed back in 2022. However, due to a lot of miscommunication, disorganization, and lack of leadership, the project failed pretty spectacularly. We ended up having several undocumented individuals who were participating in the program, as well as several individuals who were experiencing some financial hardships, be sent to collections, which broke a lot of trust within our community. And so when we kind of put this back on the table, looking at mammograms, we really wanted to make sure that we followed the CMS guidelines for a clinical quality project. So part of my role was to develop an actual A3, which is a lean and Toyota-based lean tool that acts as a fluid document and kind of tracks ongoing work and kind of a who will do what by when type document to hold people accountable, and kind of someone's role is to own that, and that was my role. So I built an A3, which is included in this presentation, and kind of owned that to ensure that we moved things forward, as well as hosting and facilitating a large task force with many individual teams. We met on a weekly and bi-weekly cadence depending on if it was the small group or the large group. And I owned that as well. So on the right-hand side, you can kind of see some of our inputs, people who were involved in our team. We had our CEO, Chuck Prosper, Rachel Lucy, the director of our Cedar Woolley Hospital, Rodney, I call him Rod, as well as our CMO, Dr. Boxler, and then some of the activities, outputs, and anticipated outcomes as well. So looking at a little bit more in depth at our annual awareness program. So as mentioned earlier, this is going to be hosted in tandem with our free screening event. Our upcoming event is actually going to be on May 24th, here in a couple of weeks. The event is going to be hosted at the local community center, close kind of in connection with the hospital. We have a shared space, and is going to have food and beverages available, as well as guest speakers who have survived breast cancer, as well as physician champions who can attest to the importance of being screened, and other community resources. So we have two physician champions, Dr. Schwartz and then Josh Schulte. Joshua Schulte has worked with Peace Health for a long time and is actually in process of developing his own breast-specific practice in Skagit County. He announced this last year, and he has been a really valuable resource, and he is actually going to be our key partner in ensuring that patients who either may not have a primary care physician or need additional follow-up get the follow-up that they need regardless of payer status or coverage. When we did our assessment, we found that this is likely going to be a pretty small portion of the people that we see. And so he was really gracious in being able to just say, yes, I will take them, I will see them, even if I have to pay for the cost myself. So he is going to be one of our speakers, as well as a woman named Barbara. Barbara is our tribal liaison and is a breast cancer screening survivor herself. She has been like a really, really critical role in kind of bridging some of those trust gaps. And so she is going to share about her experience as well. She was one of the individuals who was screened later than she likely should have been, and as a result ended up needing a double mastectomy. And so she's very public in her speaking and very open about her experience, and so she has been gracious enough to kind of host as well. And our hope is that we can kind of encourage those who might have gone without a mammogram to get one and reduce those kind of more late-term or fatal breast cancer screening diagnoses. So next up, I'm going to talk about my connections to my CEPH competencies. There were 5 that I looked at for my applied practice. The first was CEPH 14, which is to advocate for political, social, and economic policies and programs that will improve health in diverse populations. CEPH 22, which is apply systems thinking tools to a public health issue. My third was CEPH 6, which is discuss the means by which structural bias, social inequities, and racism undermine health and create challenges to achieving health equity at organizational, community, and societal levels. My fourth was CEPH number 7, assess a population needs. And then my fifth was CEPH 9, design a population-based policy program, project, or intervention. So looking at the first one, CEPH competency number 14, the way that I was able to kind of fulfill this was by looking at those gaps in our screening rates and identifying our first underserved community. And when we did our kind of more in-depth analysis of the different communities within Whatcom County that we could work with, we found that the American Indian population is the most underserved for mammograms within our kind of target area. And so this prompted us to advocate for a socially and culturally conscious free screening program to improve health outcomes within that particular population. Cultural sensitivity was particularly important given some modesty concerns and given the natural distrust that a lot of American Indian people that we spoke with have towards the organization. And our hope, again, moving forward is to increase the number of screenings and therefore prevent late-stage diagnoses. So next up, CEPH competency 22. On the right-hand side, you can see the example of the A3. This is just a screenshot of it. Unfortunately, it was much too large to include the entire thing within this PowerPoint without it being incredibly small. But so the A3 is a really good example, though, of a systems thinking tool. A systems thinking tool is a holistic way to kind of examine all the different factors and interacting parts that contribute to a possible outcome. And an A3 does exactly that. It lists the background, our inputs, our outputs, our current condition, our ideal state. It lists what our countermeasures are to any identified outcomes, and then a small kind of calendar about who is going to do what by when with additional notes. And so this is just one example in particular of a systems thinking tool, but I also used many others, such as like flowcharts, to look at how exactly this process is going to work and what the flow for the patient is going to look like. And, you know, a flowchart is another really good example of a systems thinking tool. And so there were a lot of them that were created and used to ensure that this program was successful. The next up is CEPH competency 6, discuss the means by which structural bias, social inequities, and racism undermine health and create challenges to achieving health equity at organizational, community, and societal levels. This CEPH competency was a real eye-opener for me. And there was just a lot to include on this slide, so I'm going to start with a little bit of the background. Not only did we have some pretty major barriers in trust as a result of the failure of the program a couple of years ago, the Upper Swinomish tribe and Upper Skagit tribes are definitely victims of racial assimilation. Once upon a time, there used to be 13 different really, really populous tribes in this part of the state, and we are now down to 5. And unfortunately, a lot of the elder tribal community has a lot of distrust for system level medical care and any sort of faith-based organization as a result of the Kamloops conversion schools. We are pretty close to BC. We're, less than an hour or two away. And so as a result of those findings a couple of years ago, there's just a lot of distrust, justifiably so, and a lot of healing to be done there, which is, hopefully this is a step in a small direction. But as a result of that kind of distrust, a lot of American Indian people do not feel as safe going and receiving healthcare from a Catholic or faith-based organization, which is what Peace Health is. And so we had a lot of meetings with tribal leaders and tribal community members to kind of talk about what we can do as an organization to move forward in a safe space for everyone, because those social inequities and racism have really, really led to Um, some higher rates of fatalities. American Indian women have the same prevalence rate of breast cancer screening, but they are almost 30% more likely to die from it as a result of the fact that they typically don't find out until it is too late. Um, so next up, we have CEPH competency number 7, assess the population needs, assets, and capacities that affect communities' health. So this is a really, just kind of going full circle. As part of having to make sure that this program was successful, we had to assess our population needs. So we looked at Whatcom County as a whole. We looked at the biggest areas for success or opportunities for improvement in regards to our routine screenings, and found that when we did our assessment, that mammograms was going to be the easiest one for us to target, as well as having the highest effect on community health. Then we kind of dug a little further and found that our American Indian population was the most at risk. And then we worked with our tribal leaders to kind of identify those barriers to care and how we could help reduce those. And the way that we found to help reduce those was to design a free mammogram screening program in tandem with that event, and ensure that it was culturally safe for everyone who wanted to participate. And so we have spent now the past 3-4 months building this program, designing it, running through it. We have, I think, used 20 to 30 different fake patient profiles of every different means and scenarios to ensure that all areas of potential breakdown could be addressed ahead of time. And we have gone live. And so the way that the program is now working is we are working with our community liaison, who is working directly with the patient population in case there are language barriers or concerns. We found that it was going to be better received if that kind of communication was coming directly from a member of the tribal community. So we work directly with them. They then bring us the names of the people who want to participate in the free screening program. We get them scheduled, and then the patient comes in at a time that is convenient for them, with or without someone from the tribal community, depending on what their comfort level is. And then depending on their results, we either continue to work with the tribal liaison or we continue to follow that patient for as long as they need mammograms. So my conclusion for the program was that it was really, really rewarding, being able to kind of look at and holistically use all of the skills that I had developed through all of the different classes and programs. Was really, really rewarding, particularly getting to use things like the legal law, and program design. Biostatistics really came in handy for this, just when I was looking at different patient populations and having to analyze a lot of the data that we had gathered. So that was really, really great. And reflecting on the experience, I have lived in Whatcom County now for a really long time, and was really humbled by a lot of the people that I got to meet and experiences that I had got to hear about. Breast cancer has touched so many people in our community, as well as people that I know. So getting to develop a program that could help, potentially save the life of somebody who may not have otherwise screened was really, really rewarding. And knowing that we are working together to kind of heal some of the systemic racism wounds that have been caused from the last couple of centuries was also really rewarding. But I will say, we had a couple of conversations with a tribal leader in the Upper Skagit tribe, and we had a very frank conversation about, the discovery of the bodies at the Kamloops school, which is really, really close to home for a lot of tribal members, and how Peace Health as a Catholic organization really, really let the community down. So that was really, really hard to stomach and hear, but it was really also an incredible educational opportunity for myself. I had obviously heard about the findings in the schools, but getting to hear and see the impact that it has firsthand was incredibly humbling. So I am really, really grateful for this project and getting to kind of widen my scope of understanding, and for the opportunity to learn. So thank you so much. I hope that this all made sense and was informative. I am incredibly optimistic that this program is going to be successful, and I am really excited for our event in a couple of weeks. So with that, enjoy the rest of your summer.